Dear colleagues, the first question asks whether early post-operative infection and acute hematogenous infection should be treated and managed differently. First, let's see why the consensus has chosen this question as a controversy in PGI. As treatment is mainly based on maturation stage of biofilm, we have a lot of controversy regarding the treatment strategy between these two different acute PGI, early post-operative and hematogenous one. Regarding the consensus recommendation, I'd like to draw your attention to a recent trend in favor of different treatment strategy in certain circumstances. As mentioned, there is a viable surgical procedure in most patients with acute hematogenous PGI, but implant removal should be considered in subset of patients, especially those with a crime AT score more than or equal to 3. Otherwise, the chance of their failure may reach as high as 65%.
The consensus is divided in two main sections, namely General Assembly and Hip and Knee section. At this moment, we are going to focus on a significant part of Hip and Knee section, which is treatment. We have 11 subdivisions in treatment. The first one is algorithm. Here we are going to start algorithm. We just cover some general principles, and we have 4 different questions in this subdivision.
First, let me talk a little bit about this question and see why the consensus has chosen it as a controversy in PGI. But beforehand, I'd like to stress that here we just aim to consider algorithm without getting involved in treatment details.
For the first question, it recommends that there is no evidence to support the notion that early post-operative infection and acute hematogenous infection should be treated differently as long as the onset of symptom is less than 4 weeks, favorable less than 7 days, implants are well fixed, no sinus tract exists, and the isolated infected organism is sensitive to an antimicrobial agent. There is moderate level of evidence for this recommendation. 94% of delegates agreed with it, which made it a supermajority strong consensus. Following the recommendation, there is the rationale. As the clinical practice guidelines by the Infectious Disease Society of America recommends, a well-fixed functioning prosthesis without a sinus tract with infection within 30 days of index arthroplasty or less than 3 weeks of onset of infectious symptoms and having an organism susceptible to oral antimicrobial agents is an appropriate candidate for DAIR. The International Consensus Meeting 2013, on the other hand, considers DAIR for cases in which infection occur within 3 months of the index arthroplasty with less than 3 weeks of symptoms in early post-operative infection and in late hematogenous infection if symptoms duration is less than 3 weeks. While a wide range of success rate is reported in different studies, a short period of time between initiation of symptoms and intervention seems to play a prominent role in a successful outcome. It has been confirmed in a recent study in 2020. The study defined early PGI as an infection occurring within 90 days of index arthroplasty and reported that treatment failure, which was calculated for each 2-week time interval from index surgery to DAIR, was similar, 38%. Only a higher rate of MRSA was observed when DAIR was performed more than 6 weeks after index arthroplasty. However, treatment was still successful in approximately 60% of patients. The authors concluded that DAIR is a viable option in patients with early PGI presenting more than 4 weeks after index surgery, as long as DAIR is performed at least within 1 week after the onset of symptoms. In a prospective study on 50 acute hematogenous PGI, Rodriguez showed that 52% of patients failed at 2-year follow-up after DAIR, including 57.8% in staphylococcal PGI, 14.3% in streptococcal PGI, and no failure in gram-negative PGI. In a closer review of the original study, we can see that although conservative surgery, mean DAIR, was the only factor independently associated with treatment failure, it could be the first therapeutic choice for the management of gram-negative and streptococcal acute hematogenous PGI, and for some cases with acute Staphylococcus aureus infection. Another study conducted by Bernd Fink demonstrated a noticeably increased rate of success following DAIR when intervention was within 2 days of symptoms. Success rate was 82.1% in early PGI and 57.1% in acute hematogenous PGI. Failure rate was 8 times more in acute hematogenous PGI, hence the authors called for the further surgery with larger cohort. A more detailed review of the study reveals that the rate of success for acute hematogenous infection may be secondary to this fact that the beginning of the infection and thus the actual duration of the infection cannot always be determined from the information provided by the patient. This means that the infection may have been ongoing for a much longer period. In addition, there could also be cases of declaration of the chronic infection that becomes clinically significant by acute exacerbation when a second inciting event occurs that leads to an increase in bioburden. To further clarify this result, it would be informative to listen to a part of Brian Springer's lecture in ICJR Winter Hip and Knee course in 2019.
Clearly the acute post-op infections, or the type 2s, seem to do better than the late acute hematogenous, and that's because you have that defined time period of surgery, whereas oftentimes with the late acute hematogenous, they're trying to say, well, maybe it started 3 weeks ago, maybe it started 4 weeks ago. You don't have that definitive time point. But clearly duration of symptoms and timing to get to surgery matter. Symptoms less than 2 weeks was a pretty clear cutoff for when those patients had success or failure. And some of those studies I pointed out even suggested within 48 hours those patients had a better result, probably related to biofilm, establishment of biofilm, things like that.
One study performed in Mayo Clinic, Rochester, Minnesota, and their outcome in 90 acute hip PGIs reported relatively similar outcomes in early post-operative and acute hematogenous infection. The study also revealed that grade A McPherson classification was a strong predictor of success. Many systematic studies stress that in both early post-operative and acute hematogenous PGI, timely and extensive intervention is required, with modular component exchange, because each further day of delay reduces success rate. Please note the extensive debridement of the synovium on the anterior aspect of the femur. Debridement of the infected tissue should be carried out throughout the joint, including the posterior capsule. A meta-analysis performed by Tesang in 2017 revealed that the most influential determinants of outcomes are the timing of debridement from the onset of symptoms, and the exchange of modular component at the time of initial debridement, and to a lesser extent, the time from the initial procedure. The type of pathogen also play a role in outcome of IND. Staphylococcus infection have been correlated with worse outcome. Infections with MRSA, methicillin-resistant Staphylococcus epidermidis, and vancomycin-resistant enterococci have been associated with inferior success rate after IND. In contrast, in one study, the difference could not be shown by S. aureus. In cases of infection with multi-drug resistant pathogens, a more aggressive treatment strategy is warranted, and even exchange arthroplasty either in 1 or 2 stages may be considered. In conclusion, there is a practical option and a reasonable first therapeutic approach for patients with early post-operative and acute hematogenous infections. However, some studies have reported a high failure rate and a relatively high early mortality rate after DAIR for acute hematogenous infections compared with acute post-operative infections. These differences might be related to differences in the pathoetiology of these infections and the influence of the intrinsic host factor and the outcome. Therefore, studies focusing on improving treatment outcomes after acute hematogenous infection are desperately needed. These data and the fact that hematogenous PGI were independently associated with a higher risk of failure, primarily due to a higher relapse rate than in early post-surgical PGI, suggests that Staphylococcus aureus causing hematogenous infections are more virulent and they have a higher ability to survive, like biofilm production. In fact, post-surgical strains are directly inoculated into the joint during surgery, while hematogenous strains are able to penetrate deep tissue through non or minimally disturbed barrier, evade the immune system to achieve bloodstream, and finally, they invade the joint, colonizing the prosthetic surface. When acute PGI is suspected or confirmed by the previously mentioned criteria, a debridement procedure should be performed as soon as possible. Meanwhile, keeping in mind that the patient health optimization should also be maintained. I'd like to draw your attention to a very recent study with interesting results. A number of researchers demonstrated that implant failure is higher in cases of late acute infection treated with DAIR, especially when the causative agent of the infection is SRS, with failure rate that reached 50%. Hence, they recommend that in patients with a high crime 80 score, especially if the infection is caused by SRS and a rifampin-based regimen cannot be administered, treatment strategies should be tailored and optimized to improve the outcome. In another study, this team evaluated the treatment outcome in late acute means hematogenous PGI treated with DAIR versus implant removal. Overall failure in patients treated with DAIR was 45% compared to 25% for implant removal. Their data suggests that patients with a crime 80 score equal or more than 3 will probably benefit more from revision surgery than from DAIR. DAIR was successful in only 35% of these patients, while treatment success increased to 83% when the implant was removed. A surgical flowchart suggested by these researchers can be helpful for choosing treatment strategy. As can be seen, in crime 80 score less than 3, if the organism is SRS, which is not susceptible to rifampin, implant removal should be considered. In other cases, DAIR can be performed. On the other hand, if crime score 80 more than 3 with exchangeable mobile components, if the organism is SRS, which is susceptible to both rifampin and fluoroquinolone, DAIR can be performed. Otherwise, implant removal is either necessary or should be considered as an option. When component cannot be exchanged, DAIR is out of question. Thank you for being with me through this review.